So in the next 10 minutes, I will try to show you how we, interventional cardiologists, are using CT to improve the outcomes of the patients that are undergoing PCI. To do that, we have coined this term the last couple of years that we call CT-guided PCI, which actually provides a framework to incorporate the CT in the lab. Disclosures. So the first thing that we realized this a few years ago is that when we're facing this type of disease and you are in the diagnostic setting and you ask, for example, Joao, who's in the audience, what do you think about this, this case? He will start looking at this case from the diagnostic perspective. He will start thinking, this is probably obstructive disease. It's very difficult, Carlos, because there's a lot of calcium in the cross-section. I cannot see anything. Maybe yes, maybe no. I'm not sure. But if you ask me what I'm thinking about different things. If I'm going to have this patient in the lab, I'm thinking, where's the rota machine? Where's the nurse with the rota thing? Bring the connectors. I'll probably need some special balloons to be able to treat this case. So we realized pretty soon that one image have two different interpretations. And this is how we are looking at these pictures. And we know pretty well, we have described that CT today is able to characterize all this type of plaques morphology from the early phase to the late fibroateroma. But what is very important for us is the fact that CT is able also to define calcium. And we don't see calcium as a problem. In the image we see calcium, there is calcium, tell me more about the calcium. So it's kind of it's very interesting interaction, and we can not only look at the calcium itself, we can see the arc, we can see the thickness, we can see the length, and it correlates pretty well with invasive imaging. This is one of our preliminary works looking only at calcium, and we decided to use OCT because it's a light-based intravascular image modality that allows to calculate the calcium volume. So what you see here is in the x-axis, the calcium volume derived from CT, and in the y-axis, the calcium volume derived from OCT. And you see the correlation on the screen, but I just want to focus your attention on the slope of this figure line, which is 1.6. This actually means that CT is able to really assess calcium, but it overestimated the calcium volume by 60%. So with that in mind, we took the next step, which is incorporating this inside the cath lab. And this is what I'm going to show you today. So this is a typical coronary angiography. You see here a severe lesion in the left anterior descending artery, but we don't know what is behind that stenosis. And we have doing this work and putting stents like this for the last 30, 40 years. Now, having the CT next to you inform you not only that there is a severe lesion, but what is the composition of that lesion. And you can imagine that calcified plaques are treated differently from non-calcified plaques. But the next hurdle that we found, and I know how to read CT because of a number of anecdotes in my life, but this is not the case for the majority of interventional cardiologists. And so in my lab, my colleagues don't know where the CT is located. And this is true for many hospitals. So it's like a maze to get from the CT to the cath lab. So we work a lot on bridging this gap. And here where Melis came along and we started discussing this with Peter 5, 7 years ago, more or less. And then we started coming with solutions. And the solution was, we don't know how to read these images. This is for the imagers, this is for the radiologists. We need something more fast, easy, that we can look at it, it's intuitive, and then we know what it is. So we start making mesh of the lumen, and we decided, why don't we put the plaque on top of it? And then we start putting the plaque on top of these meshes, and we find out that this is the final model. And you see here that it's very quickly the interpretation of this, and it will take you 10 seconds to understand that the white is calcium, that the red is the blood, and you see all this non-calcific plaque in green. And why is this important? Because we see this live, and this is, in my view, the first time that we can assess coronary artery disease in 3 dimensions. And for us, it's important. Why? I'm going to show you how we finalize and finally use these images. This is a video. Let me see if I can play it. So this is my cath laminals, and the images are actually integrated in the lab, and they are synchronized with the C-arm. So every time that we move the C-arm, these geometries move along. And what that actually gives you is that before you even put your foot on the pedal and you give contrast, you know exactly what you're going to see. But it's not only that, it's that you're being informed about plaque composition that actually the angiography doesn't tell you what that is. So this is the solution. This is again a video that helps you understanding not only the three-dimensionality of the plaque, but also provides you a correlation between the calcific plaque and side branches, and for us that is crucial because when we treat bifurcations we can understand how the side branch will interact. In addition to that, we have also in the software, this incorporated in the lab, measurements tool, so it's also the first time that we can measure length of disease in the three-dimensional space, and that happens again live inside the catheter. We are aware that to push this concept forward we need evidence. So we have designed and we're conducting a randomized clinical trial. It's a large trial with 1,000 patients where patients referred to the cath lab with significant coronary artery disease will be randomized to two groups. One group is the CT-guided PCI, and I'm going to explain in detail what that actually means. And the control group is what we believe is today the state-of-the-art PCI, which is IVUS-guided PCI. This is a non-inferiority trial with MACE as an endpoint at 1 year. What is CT-guided PCI? And this is where we believe that all the information, or most of the information that you can extract from a CT that is relevant to a PCI procedure. And it starts with understanding the three-dimensional tree, to understand the distribution of disease, the ostium, the lesion length, the myocardial mass at risk, which is crucial in cases of bifurcations as well. And in the trial, we're also using the solutions provided by Harvard in terms of computational fluid dynamics. What the concept behind CT-guided PCI is the fact that for the first time, we know exactly what we're going to find. So the first word is key, plan. So we enter the cath lab understanding exactly what we're going to find, then we follow an algorithm, and we finish with the optimization based on angiographic enhancements tool. This is how it looked. This is a live case performed a couple of weeks ago for New York, and this is actually in front of me, and I'm just measuring the stent length and understanding a lot of technical details that will happen after putting my stent concerning that calcific plaque in the middle. At the end of the day, this is what we have. So this is the information that we combined for the trial. So of course we have the conventional angiography. In addition to that, we have the 3D plaque morphology, and of course we also have physiology. So as a conclusion, coronary CT complements invasive angiography by informing about the plaque volume, extension, and composition. The integration of the CT real-time is today a reality. It's available, I can say, in almost 20 cath labs in the world that participate in the trial. And we think that this approach will improve clinical outcomes. In the next decade, I think that coronary CTA will become a tool for interventional cardiologists to plan PCI. Thank you very much for your attention.